Okay, good morning, folks. I think we will get started. We're a little slow gathering this morning, but in the interest of time, let's get started. Thanks for joining us again for this week. So just the usual reminders, do not disclose any private health information during your case discussions. The usual reminders about contact information, about cardio, and this is the cardio team this morning. And this is our schedule for today. So I'll facilitate as usual. Very privileged to welcome Dr. George Matar from Case Western and University Hospitals, who is in his final year of combined family medicine and preventive medicine training. We have one case to discuss today. It's really quite interesting. And we have Chris, Danette, and Mary Lee here to present, and Misty Mail will be our presenter this morning. So our usual disclosures, there are no new disclosures that I found. And with that introduction, George, please take it away.
All righty. Thank you so much, everybody. And thank you, Dr. Rao, for the introduction. So today, we're going to be talking about health equity amongst sexual minorities, and we'll also be touching upon gender minorities as well. Looking at our learning objectives today, we want to provide an overview of increased cardiovascular risk and potential causes of these risks among the LGBTQ patient population. Also going to talk about culturally sensitive and effective strategies for communicating these risks to this patient population, and how to come up with strategies to create a more welcoming environment for these patients who are seeking care. So before I get going into, answering those objectives, I think it's important to know the different terms that get thrown out for LGBTQ care. What we see, we may have seen bisexual, gay, lesbian, etc., but there's other terms such as gender expression, gender identity, and gender minority, and there's several others as well that I wanted to briefly touch on because this may come up when providing clinical care. And it's important to know how your patient may express themselves or identify. So gender expression is a way a person communicates their femininity, masculinity, or other aspects of their gender, and that would be through their mannerisms and the way they typically present themselves, such as their style of dress. Someone's gender identity is their inner sense of being a woman, a man, a combination of the two, or may not have a gender at all. And every individual that we know has a gender identity. Gender minority is sort of the counterpart of a sexual minority patient. So a gender minority is someone whose gender isn't traditionally what's expected of them based on their sex assigned at birth. So these would be transgender individuals or gender non-binary individuals. So sexual minority patients are a broad diversity of people who have a sexual orientation that is anything other than heterosexual, straight, and typically that includes gay, bisexual, lesbian, queer, or anything else. I did want to also point out the term gender dysphoria. This is a billable ICD-10 diagnosis code that you may see in patient charts. So this code describes a sense of unease that a person may have because of a mismatch between their biological sex and their gender identity. So a lot of our transgender patients will have this as their billable ICD-10 code to be able to provide them, hormone replacement therapy for their transgender care, or to have them proceed with, any type of surgical procedures that may, coincide with the care they're trying to receive. So let's talk about cardiovascular health in this patient population. So there's approximately 11 million LGBTQ adults in the US that are in this marginalized group, and they all have significant health disparities in the sense of each individual group has things they're dealing with. So unfortunately, for this patient population, we've only recently, within the last decade, started gathering data on these patients because we did not have that demographic marker in our surveillance systems. So, this is one example, the behavioral risk factor surveillance system. It did document a higher prevalence of self-reported tobacco use and cardiovascular disease diagnosis in gender minority adults. So that's one example of a step in the right direction. We're still working on including those demographic markers in other surveillance systems. So hopefully within the next decade, that will be available. The predominant theory that explains LGBTQ health disparities is the minority stress model. And this model really talks about how LGBTQ people are exposed to multi-level stressors. So this would be intrapersonal, interpersonal, and structural concerns that contribute to their health disparities. The American Heart Association actually has a really fantastic conceptual model that they've developed for cardiovascular health in LGBTQ adults. And this talks about factors other than family history and genetics or other medical comorbidities that may contribute to the cardiovascular risk factors that these patients face. So life stressors, that's a big category that this patient population has challenges with. So that would include life adversities, any financial or work and stressors, any family stressors, violence that may be occurring because of their identity. In addition to laws and social norms. So where they live, they might have more stringent laws than other locations on what they're able and not able to do with their medical care. Interpersonal care would be those prejudiced events, so the discrimination they may face in the community they're living in. Some patients are unable to leave their homes to go visit their providers, so a lot of them receive telehealth or telehealth care because of that fear of presenting into the office setting. Then interpersonal is that self-stigma, the expectations of being rejected that these patients may face. So all of these different life stressors contribute towards those cardiovascular risk factors these patients face. Moving towards the right on this model, we also see psychosocial factors. So this would be depression, stress, anxiety that these patients face. In addition, we have, as we previously mentioned on the last slide, there's increased tobacco use, poor diet quality, likely because of the financial stresses that these patients face, and lack of physical activity. And that, several studies have shown that the physical activity component is largely attributed to their inability to go out and about into their community and feel safe. Physiological factors are included in there as well. So that would be any autonomic nervous system reactivity, inflammation, and all of these contribute to the cardiovascular risk factors we see in this population, including obesity, hypertension, diabetes, hypercholesterolemia, which ultimately result in that cardiovascular morbidity and mortality that we see in this patient population. Now, on the bottom left corner of this chart, there's a social clinical determinant box. So as I mentioned, aside from these factors listed here, there's other issues such as HIV status that we'll talk about shortly that may contribute to increased cardiovascular risk factors. And there's also hormone status. So is a patient on hormone replacement therapy? These two things do drastically increase cardiovascular risk in this patient population. So as I mentioned, HIV is definitely has increased risk of cardiovascular disease. We see a higher rate of HIV in transgender women and sexual minority men. And dyslipidemia and other cardiometabolic changes are associated with certain HIV treatments. And there are also physiological effects of HIV disease itself that result in increased cardiovascular disease risk for this patient population. That chart on the right is just really stressing from the CDC that our Black African-American male-to-male patients and Hispanic Latino male-to-male patients are at a much higher risk of acquiring HIV than are other people in the population. So they are definitely a population we should be keeping a close eye on for HIV screening as well. So in addition to HIV, we also have the use of gender-affirming hormone therapy, which is identified as a potential contributor to poor cardiovascular health in transgender patients. And this is one study on the right that talked about the cardiovascular outcome in gender dysphoric patients who received hormone replacement therapy, primarily transgender women who were receiving estrogen therapy. So what they saw in this study was that there was an increased odds of ischemic stroke, pulmonary embolism, STEMI and STEMI, drug abuse, and hypothyroidism in these patients that were receiving hormone replacement therapy. And the important thing to note about this patient population also is age. So a lot of these patients in this population were originally elderly cisgender males that were transitioning to become transgender females who already had an increased risk of cardiovascular disease based on their age and other risk factors, genetic risk factors as well. So we talked about hormones. I wanted to break that down a little bit more just so we can see what the risks are. So starting with estrogen, estrogen has different formulations that can be given to the patient. So there's oral estrogen, there are transdermal patches, and intramuscular injections of estrogen. So in the clinic, in terms of the safest option for cardiovascular risk factors, we usually try to start with a transdermal approach of estrogen or even intramuscular, because the oral formulation does have first-pass metabolism with the liver, which does increase risk of prothrombotic and pro-inflammatory events occurring in our patients. So if you have a patient that is at an increased risk of having a blood clot or already has medical comorbidities such as hypertriglyceridemia or diabetes, oral estrogen would not be an optimal starting therapy for this patient population. So that's just something to note, because we do see that with estrogen, we do have an increased risk of what I mentioned, including gallstones, weight gain, etc. Looking at testosterone, the two availabilities that we have to give to our patients right now that are readily available are intramuscular injections as well as a gel, testosterone gel product. So testosterone does increase risk of polycythemia, weight gain, acne, androgenic alopecia, sleep apnea. We do also see increased elevated liver enzymes and hyperlipidemia. So these do increase cardiovascular risk factors for the patients. So it's important to know, what your patient's risks are when you're doing your initial assessment on them, and how can you, I guess, for lack of better terms, meet them in the middle with their care in terms of providing the care they need, but also ensuring that they're going to be safe with the care that they receive. So with this information, do we need to turn away our higher cardiovascular disease risk trans patients who are seeking hormone replacement therapy? Well, it's a hard to answer question, yes and no. It's really a shared decision-making process. So why is that? That's because our trans patient population have other risk factors that we really need to worry about other than what we see from the hormone replacement therapy. So this is where that health equity component comes in. So trans patients are, 21% of them avoid going to the emergency room out of fear of discrimination. They're 5 times more likely to attempt suicide. They have a much higher HIV infection rate than the national average and regular population. Higher rates of drug use, sexual assault, domestic violence, and much more likely to have extreme poverty and be unemployed. So when you're talking about providing care for your trans patients, you really need to think, okay, they're at higher risk of a cardiovascular event from occurring if I start them on hormone therapy. But if I don't start them on hormone therapy, or even start them at a lower dose of hormone therapy, am I going to be causing more harm to the patient from that aspect rather than starting them on the therapy itself? So it's important to really weigh the risks and benefits of starting hormone therapy, having that clear discussion with the patient, having that shared decision-making process take place to ensure that the best possible care is being provided to your patient population. And to take it one step further, it's really important to understand and be culturally competent when providing this care to this patient population. So there are several ways that we can do this as providers in a clinical setting and a non-clinical setting to make these members of the LGBTQ community more welcomed into the setting that we're trying to see them in. So first, advertising practices as accepting of members of the LGBTQ community. Then educating staff and providers to be comfortable in discussing sexual orientation, gender orientation, and sexual practices. Include members of the LGBTQ community as part of your staff and train your staff to refer patients by their name or chosen pronouns. maintaining an open mind, avoiding judgment regarding sexual orientation and practices, adjusting intake forms to include the term partner in addition to spouse, including transgender as an option to check mark as well, participating in referral programs such as the Gay and Lesbian Medical Association or Gay Health, which allows patients to see your name listed as a provider that's LGBTQ friendly. In addition, posting LGBTQ symbols and posters of ethnically and racially diverse transgender or same-sex couples, providing patient brochures on sexually transmitted diseases, substance abuse, safe sex practices, information on hormone therapy, waiting room magazines, and of course, supporting observance of, LGBTQ Pride Days, World AIDS Days, etc. And lastly, to tie it all together, once we've gathered that cultural competence and are now able to provide that cultural sensitivity, we're really prioritizing the patient's narrative. We are giving the power to the patient to be able to define their care in the clinical setting and feel empowered to seek the care they need so that they have appropriate health equity. So that's sums up my presentation. I just, main point here is being able to provide care to all patients that fall into any gender marker, sexual marker, etc. And we can do it in a safe way while also being culturally competent.
Thank you, George, and thanks for a fantastic presentation. It's troubling to see that so many members of these communities avoid healthcare for fear of discrimination. Do you think we've made any progress in that regard? I mean, some of those recommendations you made, we're doing, for example, in our department, and I assume others are doing it as well. Are things getting better in terms of
So things are getting better. And one of the reasons they are is because we now have guidelines that we didn't have before. So we have the World Association of Transgender Health actually has now released guidelines that we can follow. And a lot of providers and, they need these guidelines to feel validated to provide this care and make it something that's an option for these patients. So, which is good and bad, but the fact that we have guidelines available, that many clinics are adopting these practices that I listed to provide culturally competent care, and that we're now including this patient population in our national surveillance systems, it really is showing that the country as a whole is starting to recognize the LGBTQ community and see what their cares and needs are.
Great, thank you, George. Any additional questions for George?
This is Paul. I've got one quick one, if I may, Dr. Rao. Dr. Matar, thank you. Fascinating presentation. I'm curious, and it shows where I'm at, so I don't mind asking questions that reveal my ignorance. When it comes to the hormone therapy, what percentage of a transgender population, if I may use this term, needs hormone therapy? What are some of our goals with the hormone therapy? How many people are happy and healthy without hormone therapy? Can you break that down for us?
Yeah, there's a lot of patients that don't seek hormone therapy. So primarily they just want therapy to talk about their wants and needs. And they may just want to just be addressed and find out ways that they can express themselves as a transgender woman or a transgender man without the need of hormone therapy. I actually have several patients that are not on hormone therapy and come and seek care for me for their primary care, and mostly are receiving therapy or counseling sessions to figure out how they can present themselves as the opposite gender without having that hormone replacement therapy approach. So there are quite a few patients who are on hormone therapy, but particularly my transgender elderly population, I have them on minimal to no hormones at all. And we just find different approaches on how we can make their care fair for them, and we meet them halfway. So no, not all patients are on hormone replacement therapy because of risk or because of preference. And, for example, we have some transgender female patients that are just on spironolactone, just to have that, gynecomastia effect of spironolactone, but not be on estrogen replacement therapy. So they're not getting that higher cardiovascular risk of being on estrogen therapy, and they're just on spironolactone. So,
thank you.
Yeah.
Thank you, Paul. Any additional questions?
Hi, this is Mary Lee. Quick question, and I missed the first couple minutes of your presentation, so I just want to make sure I understood what you were saying correctly about the cardiovascular disease. So I do some hormone therapy with one of our physicians, and it's a very small number of patients, but generally patients who are established on hormone therapy before they come in and just need like continued monitoring and, you know, things like that. So I recently, though, got a referral for a patient who is born male, wants to transition female, who is younger, like mid-30s, who has a history of TIA, hypertension, dyslipidemia, and I mean, I need to do some more digging into this and understand the literature a little bit better, but it sounds like from what you're saying, that is not like a contraindication to using estrogen therapy, looking more at like shared decision-making, what the patient's goals are. And then you just mentioned potentially only using like spironolactone. In that case, I didn't even think of that. Is there any other considerations for a patient that sound, you know, that I just kind of described?
Yeah, so if you have a patient that's higher risk, I mean, always start with a transdermal. If you're going to start estrogen therapy, you want to do a transdermal approach because it has the slowest release of estrogen and it gives it in these like smaller doses and increments. So the patient may start feeling the effects of estrogen, but not quite as rapidly. And it bypasses that first metabolism that I mentioned. But again, you can start with just spironolactone because sometimes the effects of gynecomastia that we see with spironolactone also, there are these patients that are really gender dysphoric preliminarily around their genitalia, primarily around their genitalia. So spironolactone also helps reduce, you know, erections and such. So that's something that patients are also looking for as well. So sometimes with that alone, you can actually achieve the goals the patient's looking for without having to proceed to the estrogen replacement therapy that will increase cardiovascular risk.
Okay, thank you.
Yep.
Thank you, Mary Lee. Just back to Andy for a moment.
Thanks, everyone.
Just as a reminder that our May webinar is coming up and you can register on our website with the QR code or at cardio.org. All past and present echo clinics are available on our website. And then you should be receiving a post-clinic survey in about just a few minutes. Please complete that by tomorrow at 5 p.m. Thanks.
All right. Thank you, George, for being our special guest with a great presentation. And thank you, Misty, for a very interesting case as well. We'll see you all next week. Bye-bye.